right, gotta let everybody into the room here. All right, everyone, we're going to do a couple things today: physiology of aging and also some understanding mature adults. So we're going to start with physiology of aging. Can everybody see my screen okay? Screen share has been acting a little weird lately. You guys all seeing this before I go full slide? Okay, so this is really a section in the course where it's mostly, don't know why it's saying my screen share is paused. Hold on a second. This is a module, Physiology of Aging, where it's mostly reading material. I don't think we have a video for this. Not sure how we would have filmed a video on Physiology of Aging other than for us to do a lecture. But so it really is reading material. So, all right, you should be able to see this now. Let's see if I can get this to go full screen. Come on. There we go. Okay. So funny. All right, can you all still see my screen? Okay, I think I've got somebody else to admit every time somebody jumps in. Okay, so just quick review again, functional aging training model, the visual. And Sally, you seeing my screen okay? Seeing the slides? Okay, I don't know why it's saying that it's paused. So, so there's definite aging things that happen. We can't just say, we're gonna treat people as if they're young forever, right? That's a mistake, and we have to acknowledge there's a physiology of aging. Musculoskeletal things, we're going to see loss of muscle mass, loss of strength. Type 2 fibers are going to change. We're not going to be quite as fast. But that question doesn't mean that people can't still have a high level of function. But we do have to realize an 80-year-old is not going to be as fast as when they were 20. There's going to be a change. There's going to definitely be a change in even bone density. Women tend to be at higher risk for osteoporosis. But it's not just a female issue. Men struggle with this as well. So collagens changing, cartilage and joint lubrications changing, subcutaneous fat, intramuscular fat. Typically our muscles become more striated with intramuscular fat, that marbling you see in meat. So there's degenerative joint disease. It's going to be much more common for us to see spinal degenerative joint disease in someone who's 60 than in someone who's 30. It's part of the physiology of aging. So when we look at, this is what I was just talking about, sort of that striation of muscle tissue, right? When we look at a 40-year-old triathlete, I mean, lots of skeletal muscle. You see the bone there in the center and the subcutaneous fat around the outside. Sally's waving her hand. Are you guys, what's up, Sally?
Are you moving slides? Because all I'm saying is the statement of physiology of aging.
That's what I thought. So it
Oh, okay. There's nothing moving.
All right, let's just go this way with it then. Can you see this okay?
Yep, that's on. Yep.
Okay.
Thank you.
So I'll leave the outline on the side here. For some reason, when I'm going to full presentation, it's pausing my share. So here's the list I was going over of just some musculoskeletal changes, right? We see bone density change, muscle density change, muscle fiber changes, loss of cartilage, joint lubrication. It's it's not realistic for us to say, oh, well, I'm gonna train you just like you're 20. A 65-year-old doesn't have the same knees as a 25-year-old. They just don't, right? The joint structures aren't the same. The cartilage is no longer the same. The joint lubrication's not the same. And so to think that a 65-year-old can take 80 burpees just like a 25-year-old can is probably not correct. Doesn't mean they can't do high functioning stuff. Doesn't mean we're going to say, oh, you're 65, so you can't jump. No, but we're also going to have to be a little bit smarter about it. And then, so it's interesting when we look at, right, this typical aging view of how muscle changes. Well, look at the 70-year-old triathlete. Looks pretty similar to the 40-year-old triathlete compared to the 74-year-old sedentary man. So is it really aging, or is it 30 years of lack of use? Well, we know most of it, of course, is lack of use. It's deconditioning. It's not I'm 70 years old, because the 70-year-old can still have great muscle tissue, great muscle density. So, but the 70-year-old triathlete is probably not going to have the same knee cartilage, probably not going to have even the same bone density as a 40-year-old triathlete, and certainly might not be as strong as when they were 40 years old. So there is going to be a decline in muscle mass and function, but the variability, of course, is going to be huge. And when we look at leg power, we start to notice a much bigger difference. So we decline a little bit in strength, decline a little bit in leg muscle area, but our power is dropping off much faster. And so one of the things we notice with a greater change with age is power and speed. And those are, of course, impacted by leg strength, leg muscle area. So as we lose force production, we lose strength and also lose speed, we see that manifest in a bigger loss in power. Strength and power are things that we continue to look at the Functional Aging Institute, and research is continuing to look at it. It seems pretty clear now that leg power is much more predictive and determinant of physical performance. And so we have to be training power for sure. In fact, you look at all these different tests: stair climb time, chair stand time, tandem gait, maximal gait, habitual gait, short physical performance battery. Leg power in every case is more significant than leg strength. That's not to say leg strength isn't important, and we always have to realize, well, leg strength is half of the equation of leg power. So if I lose leg strength, I'm losing leg power, right? If my leg power is low, I already know my leg strength is low, right? So they're very correlated, of course, right? Because it's strength times speed equals power. So if my strength is poor, my power for sure is going to be poor, okay? If we look at hand grip strength, not just looking at power, look how this changes across age. So normal strength, 60 and over, 60 to 69, 80 and over, we're losing strength with age. And we start to see more of that as we get into our 80s, is where we start to see, the strength is much more of a factor now for someone who's 80 years old. And so while we teach you to not be ageist, and we teach you to believe that people can be healthy, fit, vibrant at any age, we also have to realize people in their 80s and 90s are probably, the physiology of aging is going to tell us their strength may become much more of an issue. And so we have to realize that. Here's just another look at that hand grip strength. Percentage of adults age 60 and over with difficulty rising from a chair by muscle strength. You start to see the percentile charts here. Strength becomes an issue. But this is an interesting chart because we're looking at hand grip strength overlaid with chair rise. So if people have poor hand grip strength, there's a correlation that they're going to be weak muscle strength rising from a chair. So that's sort of interesting. Sarcopenia is a term you should all be very familiar with. Basically, it's progressive and generalized skeletal muscle loss. And it's going to lead to things like falls and fractures, physical disability, and can even be predictive of mortality. Low muscle strength is the primary parameter of sarcopenia. So this is muscle loss. Muscle strength is presently the most reliable measure of muscle function. So if you don't have muscle strength, in most cases, you're not going to have good muscle function, right? If you don't have good quadricep muscle strength, you can't get out of a chair, you can't climb stairs, you can't do some of these functional tasks that require muscle strength. Specifically, sarcopenia is probable when low muscle strength is detected. So sarcopenia is loss of skeletal muscle mass. Similar to osteopenia is loss of bone mass. I don't ever hear anybody say sarcoporosis though, so that's a bone term. You hear osteopenia, but you don't hear sarcoporosis. When low muscle strength, low muscle quality, low muscle quantity, and low physical performance are all detected, sarcopenia is considered severe. And this is typically when we see people start to be categorized as frail often, right? They can't get out of a chair on their own. They might not even be able to walk without a walker. They're really demonstrating such a lack of physical strength that even caring for themselves could become a risk, right? Like going to the bathroom, can't do that on their own, things of that nature. So sarcopenia is a pretty significant concern. We've got to the level of loss of muscle at this point where so many basics of activities of daily living are a challenge because I don't have the strength to do it, cooking and cleaning and those sorts of things. So prevalence of sarcopenia, you can see it starts to rise with age, but it's certainly more a female issue. So 70s is where we start to see it start to tick up a little bit, especially with women, people over the age of 80. It's not not like we would think, oh, if you're in your 80s, it must be like 30% of people are dealing with sarcopenia. No, that's not the case. The prevalence is still only around 11% for those greater than 80 years old. So again, this is why we can't just assume it's about strength and muscle mass, because so many individuals still have plenty of muscle mass, plenty of strength to function. It's a combination of all the other things as to why they're not functioning well, right? Their balance isn't good or their speed isn't good, so they've lost power. There's more to it than just muscle mass and strength. Now, interestingly, it's different across countries, and I think some of this is some of these countries are living even longer than us. When we look at, I was showing you the USA statistics, the prevalence, it's much higher in Japan, much, much higher. And I think part of that is they have many more people living longer into their 80s and 90s. But some of that could also be lifestyle factors. It also could be that they're smaller individuals, and so the aspect of loss of muscle mass becomes more prevalent, but not really sure exactly why that is. I know Japan certainly has more longevity than the USA does. So it's just sort of interesting. You notice in the UK and Taiwan, it's significantly lower than in the United States. So I'm going to jump through some of the rest of this sarcopenia stuff because we could probably spend 2 hours just talking about sarcopenia, but there's lots and lots of different assessments. Grip strength is a common one we see because we know once people have lost upper body, basic upper body strength to grip things, to hold things, grasp things, that's going to have implications for activities of daily living. Dressing myself, bathing myself, grasping objects, carrying objects, picking things up. There's a correlation to grip strength. So we see that quite a bit in the research literature because it's a simple test. We can assess it very quickly and then have a suspicion that someone's already beginning to struggle with muscle mass. So again, you see some research on low muscle strength, hand grip, dynamometry, chair stands, and we see low physical performance on gait speed, short performance battery test, timed up and go, 400-meter walk. So it's really interesting. Very quickly with grip strength, we can begin to diagnose that this is going to be an issue. All right, I want to jump through the sarcopenia. Yeah, on to neuromuscular stuff. So other things happening with our physiology of aging. we're losing some neural innervation of muscles. We're starting to break down some of these pathways where our neurons are telling our muscles to fire and do different coordinated things. This is starting to decrease, which of course is going to impact so many different things: our response time, our speed. It's slowing our motor impulse speed. So this is going to decrease our reaction time. It's going to decrease our movement speed. We can't move quite as fast, react quite as fast. It's going to give us more variability in our gross motor performance. So things like a karaoke or a stepping pattern where I'm crossing over my feet and doing different large motor patterns. I might do it really well on rep 1 and 2, and then I have more variability repeating it. It's like, why can't I repeat this task? I just did it. So we're going to see more variance here. Fine motor skills are going to be impaired, right? My ability to use my fingers to do certain tasks like, thread a needle or, sew a button on a shirt and do some of these things. It's like, well, I know how to do this task, but I can't get my fingers to do it. Fine motor skills can start to be impacted. And this can have implications for things like, opening the mail and cutting open a package and using scissors and all these fine motor skills, which of course we need. And we also see some neuromuscular declines in so many multisensory inputs, right? So our vestibular function might not be quite as sharp or attuned. Our sense of touch might not be quite the same. Our sense of smell might not be quite the same. Lots of different sensory inputs are declining. The physiology is not quite as sharp as it used to be. And that has an impact, right? If I can't sense the pressure like I used to in my fingertips, well, that's going to impact how I grasp something. It's like, why did I break that thing in my fingers? Well, I wasn't sensing how much pressure I was putting on that delicate item, and all of a sudden I broke it in my fingertips. Or the opposite, I'm not holding it, with enough pressure, and I drop it, or I can't keep a hold of the item. So lots of things happening there. More on multisensory. Obviously, vision is a huge one. Where most of us, assuming you're not a visually impaired or blind person, most of us are very, very vision dependent. It's our dominant sensory input. We trust what our eyes tell us. We trust it for movement. We trust it for ambulation. We trust it for so many things. And this is going to decrease more so after the age of 75. So we start to lose the ability to detect some contrasts, depth perception changes, decreased illumination with the eye. We're more increased sensitivity to glare. This is why driving at night can become more problematic, especially after the age of 75. Macular degeneration, glaucoma, cataracts. Cataracts by far the most prevalent. And of course, that's something that can be fixed now. But there's just definite changes with vision. We don't have the same visual acuity in our 70s, 80s, and beyond as we did when we were children and in our 20s and 30s. It's just not quite the same. And because we're so vision dependent and we haven't learned to trust our other two senses, that becomes problematic. There's also decreased planar receptor density and sensitivity, somatosensation, right? Our ability to sense how much pressure are we putting on our feet, on our toes, on our ankle. Those things are changing. There's also decreased joint position and joint motion awareness. My knee is not telling my hip what my ankle is doing quite as quick as it used to. The old song, the bone, the thigh bone's connected to the knee bone, and all that's an issue as we age. That physiology is changing. And part of that is why we tend to move a little bit slower and we react a little bit slower, because my hip doesn't know exactly where my knee position is in relative time and space to my foot as quick as it used to. And when I say quick, we're talking microseconds, right? I mean, if I want to run across a room, well, I really need to know where my foot and ankle are in relation to my knee and my hip as I'm doing that. And so I'm probably not going to run quite as agile as I did in my 20s and 30s. Of course, vestibular function, hearing loss, lots of different factors at the ear as well. And hearing loss and vestibular function are two different things, right? Our auditory sense is not the same as our vestibular sense, but things that are happening in our ear are certainly changing with age as well. So just because someone is having hearing loss does not necessarily mean they have vestibular dysfunction. But of course, loss of hearing impacts our senses. And as people become more and more deficient in their hearing, and you notice 50% over the age of 75 have disabling hearing loss. I mean, it's at the level that if they're not using a hearing aid, and this is 50%, so not everybody, but if they're not using a hearing aid or some sort of hearing device, they're having a loss of hearing at a level that is considered disabling, meaning they can't carry on a typical conversation. They can't necessarily hear things on the phone. They might be out in their environment and not realize what traffic is doing and things of this nature. So strongly encourage people in their 60s to be hearing screened and begin using hearing aids. One of the problems is people don't catch it till it's too late, or they're resistant to be tested, and all of a sudden they're 75. I'm not suffering hearing loss. You're already at a major loss, but the last thing you want to do is get a hearing aid and do anything about it, because that's such a major change. So we have to encourage people to seek out help for their vision and their hearing both. Make sure they're being tested, make sure they're basically using all the amazing things we have to help them, right? So hearing aids have gotten remarkably better over the last 10 years. The technology is incredible, and in most cases you can barely even tell someone is using a hearing aid, and it really impacts so much of our sensory input. So we've gone over musculoskeletal, we've gone over neuromuscular. Here's some cardiovascular things. Now, by now, you're probably starting to get slightly depressed, like this is sort of sad, right? We are physiologically aging. We're going to decline. Our maximal oxygen consumption is going to go down. Our VO2 max at 75 is not going to be as high as it was at 25. It's just not. Our heart muscle's not the same. It's not as efficient. We have a decrease in cardiac output. We have a decrease in arteriovenous oxygen difference. If you're not familiar with what that is, I encourage you to look it up. But basically what it means is we can't move as much oxygen into the muscles and into the cells like we used to when we were younger. Our cardiac output's not the same, so our heart muscle is not pumping out quite as much blood as it used to at quite the rate. Our heart rate's down. And 220 minus age is the age-old prediction for max heart rate. Well, that gets kind of discouraging when you go from 20 years old doing research studies, which is really who we use for a lot of these research studies. I remember, being in the exercise phys lab when I was 20. It's like, oh yeah, my predicted max heart rate's 200, and we would try to get people up to that. I think they got me up to 189 on one of the tests, and they were like, that's it's probably as far as we're going to get you on this piece of equipment. Well, when you're 70, it's like, wait a minute. 150, that's my max heart rate. Obviously, you're not going to be able to produce the same kind of cardiovascular output with a heart rate of 150. We have decreases in left ventricular ejection fracture. Some of these things get pretty technical in the cardiology. Again, you can look that up. But basically what's happening is our left ventricle is not pumping out as much blood. There's also not quite the same efficiency. So as blood comes into the ventricle and then pumps out, it's not quite fully getting all the blood out, which is just part of the aging heart. It's not quite as efficient. Blood vessels become thicker and stiffer. They're not as elastic as they used to be. If you think of that garden hose, right? It starts to get a little bit stiffer with age. If you've ever had a garden hose for 20 years, you notice that garden hose starts to get a little stiffer with age. Increased risk of hypertension, cardiovascular disease. Some of those things are lifestyle dependent. Some of those are genetic. I mean, I've known individuals who had the absolute most active lifestyle you ever see, and they still had high cholesterol and borderline hypertension. In fact, the hospital where I interned, I think my boss was in his upper 50s, He was the fittest guy I knew cardiovascularly. He could ride a 100-mile bike day. He was a cyclist, raced all sorts of events in his 50s and 60s, and was a world-class cyclist in his 20s and 30s. Guy had cholesterol through the roof, and it was a genetic thing. So lots of different cardiovascular changes with age. Balance and mobility, lots of different systems impacted here. Most of this is what we call a combination of all those other systems, right? So we don't necessarily have a balance and mobility physiology. What's driving our balance and mobility is neuromuscular and power and strength and all these other domains that we've already talked about, most of multisensory. If I can't feel my feet like I used to, if I don't have the joint proprioception like I used to, the neuromuscular, if I don't have the cardiovascular function, I go up 2-3 flights of stairs, or I hike up a half-mile uphill grade, and I don't have the cardiovascular fitness I used to have. I get to the top and I'm winded, I'm out of gas, and all of a sudden that's going to impact all my other systems. And so balance impairments and falls, we know, are serious threats. There's gait changes. I'm not getting the toe clearance I used to get. I'm not quite picking up my foot. My stance has gotten a little wider. My steps have gotten a little shorter. I've slowed down a little bit. I mean, try walking across a room with shorter steps, slower steps. You'll notice it's actually harder to keep your balance, right? Try shuffling across a room. Shuffle your feet and you realize this is not so easy. And of course, we see polypharmacy becoming an issue as people are on more and more medications. Once you get to 3 medications or more, your risk of falling goes up dramatically. And with each and every medication you add, your risk increases. So the fall statistics, I mean, they just really bear out the concern for the physiology of aging. Let's see. So you can see 1 in 4 older adults reported a fall, but an older adult falls every second of every day, but less than half talk to their doctor about their fall. So if 1 in 4 older adults report a fall, and we know roughly half of older adults aren't reporting falls to their physician because they were minor. I didn't, like, I'm not going to tell someone I fell down in the living room and I got up and I was just fine, I fell into the bed or the couch. So we know we're not getting full statistics on fall data that's out there, right? What we're really getting is self-reported falls to physicians, and then of course falls that wind up in the emergency room or medical treatment, which is a staggering number. It's over 30 billion. And a lot of estimates I see now, we're already over 50 billion in medical costs annually for fall related injuries. It's difficult to get a full grasp on that, but when we look at 7 million injuries, that's pretty staggering. 2014 numbers, 2030 numbers, 10 years from now, we're anticipating 12 million annual injuries from falls. That's a huge number, huge number. So, all right, let's see what else I wanted to cover here with you guys today. There's a lot of, I want to talk about the brain stuff. So, the fall rates really should be alarming to us. They really should be. This is a significant crisis in our country, and the number of fall deaths are going to become staggering on a daily basis. And much of that is preventable. It really is. If we would start training balance and lower body strength and power for people, especially over the age of 70 and 75, we could significantly reduce this. So people should not have to be 86, 88, 92 years old, and they can't get out of a chair, they can't get off the toilet, and they're falling and dying in their bathroom. But it's going to become a huge problem here. It already is a huge problem, but the numbers are really climbing. The death spiral is probably not one of the more encouraging things to talk about on a Friday afternoon, but this is something we need to be aware of. A person falls or almost falls. They have fear of falling again, or their fear of falling increases because they've fallen. They self-impose activity limitations. Well, I'm not going to go do that risky thing again. I don't think I'm going to go for a walk with my friend again, or I'm not going to climb stairs in my home anymore, or I'm not going to go to that church potluck because the last time I went, I mean, you name it, whatever that activity, I'm not going to bridge club, whatever that activity limitation is, it's accelerating their decline. A loss of movement leads to accelerated physiological loss and reduced mobility and physical fitness. This person's now at higher risk of falling than when they started. You know, it's that age-old concept of you got to get back up on the horse again, right? So I've fallen, and so therefore I'm not going to walk in my neighborhood anymore because I don't want a sidewalk crack to jump out and get me. And so now I'm not walking at all. And so my physical level goes from already low to even lower to pretty soon there's no way to turn it around, which is why it is called the death spiral in gerontology research literature. It's a sad phenomenon where we see somebody go from low independent functioning to dead and gone within 6 to 12 months. Well, how did that happen? Well, a series of events spiraled to that decline where somebody went from lower independent to essentially gone. Now, that there could have been a major injury along the way, right? I fall and I break my hip. Well, that is going to really self-impose activity limitations. But in some cases, it's not that. It's I fall and I didn't get seriously hurt, but I'm so afraid of falling and breaking my hip that I basically become a self-fulfilling prophecy because I'm not going to put myself at risk of that ever happening to me. And now I physically decline so quickly that I wind up getting the same outcome. And so we have to be encouraging people to do the opposite of this, right? If you have the fear of falling, then we have got to train you to have more confidence. We got to train you to do more. We have to reverse this quickly because if you start to self-impose activity limitations, right? Well, I'm not going to go out because I don't want to take a risk. You're putting yourself at greater risk. You can't. That is not a protective behavior. ABCs of why older adults fall. There's a lot of things that go into it. It's way more complex than just, oh, you got weaker or, oh, you haven't been training your balance, right? There's medications. Exercise level is probably the biggest one we can impact. But there's so many different things. We know that age is a risk factor for falling. If you're over the age of 75, that's a significant risk factor for falling. Oftentimes, because we see people over the age of 75 have poorer balance, they have chronic conditions, they may begin to have cognitive deficits, they may be on multiple medications, they have all these other risk factors. So there's a lot that goes into it. There's a lot of things we need to think about addressing holistically, not just the fitness, right? So we can impact the fitness, the exercise level, but if their home environment is dangerous, right? They have too many rugs on the floor, they have dogs' toys scattered about. Dr. Chris Thompson gave a great illustration of this yesterday in his presentation. 2 days ago on Wednesday, he gave a presentation and he talked about the 82-year-old male with BPH, right? Benign prostate hyperplasia, right? He's got an enlarged prostate. He's also diabetic. He's hypertensive. So what are they giving him as a hypertensive diabetic? Medication that makes him have to go to the bathroom. A diuretic's going to have to make you go to the bathroom. You got an enlarged prostate. You're going to have to go to the bathroom. Well, guess what? He's got to get up 3 or 4 times a night to go to the bathroom. And he's got a dog. We got a triple whammy here, right? He's got to get up in the middle of the night, go to the bathroom. The dog leaves 2 or 3 toys somewhere scattered about the room. And pretty soon he has a major fall in his bedroom or bathroom, trips over a dog toy, down he goes. And who knows how long it is before somebody finds him, right? Or he's able to get help. So it's sort of a triple whammy, right? It's almost the perfect scenario for how this can happen. And of course, we don't want to tell him, well, you shouldn't have a dog. No, of course we want you to have a dog, walk your dog and, have those sorts of things. But we realize the environment we have to think about, the drugs that you're on, we have to think about, and then what are the training things we need to do so you can get up in the middle of the night. And we have to teach him probably, when you get up at night to go to the bathroom, turn a light on, because wander into the toilet in the dark, you're not going to see that dog toy. You're not going to notice your environment. You're very vision dependent. So turn a light on. So there's just a lot of things to think about. So the cognitive aspect of the physiology of aging. Boy, time is flying. We're at 1:38 already. There's just so many different things going on cognitively. The continuum from normal cognition to mild cognitive impairment, to dementia. Again, these are not normal conditions of the aging process. It's not to turn 80 is to have dementia. To turn 90 means you'll have Alzheimer's. That's not the case. But there's a lot of links to brain health and other aspects. Cardiovascular disease is certainly linked to it. There's a lot of other things. We typically see mild decreases in visual and verbal memory, visio-spatial abilities, immediate memory. We see an increase in crystallized intelligence, acquired knowledge and expertise, such as in an occupation. Those things become increasingly crystallized. And I can give you an example. My father-in-law is 81, and I'm seeing some decreases in his immediate memory. But man, his crystallized intelligence at the skills, he was a licensed funeral director, pretty confident he could probably embalm bodies for the rest of his life. I mean, it's like just crystallized. The skills he's really good at from his occupation are really there. Depression is more common in hospitalized older adults, disabled, poor health, chronic pain, certain medications. So mental health is a huge issue. I mean, look at the 65 plus age group has the highest suicide rate. We hear all the time about teenage suicide rates are climbing, and young adults and college age kids, and suicide rates among veterans are just heartbreaking. But the 65 plus age group has a really high suicide rate. And most of that is due to mental health. Some of that is due to the significant loss of a significant other is not something they have coping mechanisms for, right? So I'm 67 years old and my spouse dies. I have no reason to live anymore. And we see a tremendous suicide rate, especially in men over the age of 65 when they have a major loss. Loss of a spouse and loss of a child can be a significant one. So normal aging with cognitive changes are really the upper two green lines. We're going to see some decline in the physiology of our brain. The not normal is to drop off the chart here onto this dark blue and red line, where we go from mild cognitive impairment to dementia. And that is not normal aging. So I don't want you to feel like the normal aspect of aging is Alzheimer's. That's a disease. It's not normal aging. But we want to be aware of these cognitive changes in our cognitive abilities, and we want to be thinking about how we can impact them. And so there's just a number of things we need to think about cognitive skills in the aging brain, and it might even impact how we train people in terms of their working memory and processing speed and problem solving and decision making. Like, don't throw too many things at people all at once. Let them master and learn things, one at a time. So there's so much that goes on with brain health in terms of exercise. I certainly can't cover it all here today in a short amount of time, but I want you to think about all the positive things of neuroplasticity. We know the brain continues to adapt and can continue to improve with age. So active lifestyle, antioxidants, good sleep, good health, physical exercise, all these things can increase the synaptic density of our brains. Just like the opposite, right? Non-stimulating activities, sitting too long and watching television too much, and poor nutrition and poor sleep hygiene and negative mood, poor health, sedentary lifestyle. These things actually can decrease the synaptic density, the neuroplasticity of our brain. And so the brain while it's not a muscle, we can think of it that way. If we don't use it and we're not stimulating it, it does begin to shrink. And so we have to keep it active, but we also have to do a lot of other positive health things, right? I mean, if we have sleep apnea and we don't get it treated, it has a huge negative impact on our brain health. If we have sleep, not apnea, but sleep disruptions and poor sleep habits and, poor sleep hygiene, has a huge impact on our cognitive function. And so you can do all the exercise and brain games and brain health things you want. If the person has sleep apnea and is not sleeping well, we're probably not going to see a huge improvement in their cognitive function. So there are some basic things we've got to make sure we're addressing. So when we look at how physical activity impacts the brain, right? I mean, we know physical activity almost right away impacts mood. We get positive changes there, but through physical activity and exercise, we're going to get some molecular changes, some BDNF changes, some neuronal changes, especially if we're doing complex movement patterns. We have to lay down new neural pathways. This concept of neurogenesis, it's like, learning how to dance, learning a new movement pattern, learning a new stepping pattern, all these things, our brain has to go, wait, I have to figure out how to do this so I don't have two left feet, or I'm not stepping on myself or stepping on my dance partner, or, any of those sort of things. So this is one of the reasons why it's so great to encourage someone really at any age. I don't care if you're 30 years old, to take up a new sport or learn a new game or learn a new activity. Because guess what? Your brain has to expand and grow. And that's even true even outside of physical activity, right? Like learning an instrument or learning a language. Your brain obviously has to lay down new neural pathways, right? If I'm going to learn to play the piano or the guitar, of course, that has physical motor skills involved as well. I mean, try tonight, just for kicks, brushing your teeth with your offhand. I mean, you'll be surprised, like, man, my brain is not good at this, right? I can't brush my teeth with my left hand. Why is this so hard? So your brain can learn how to do that. It absolutely can. So there's lots of things we can be thinking about. So just another visual in terms of brain stimulation, right? We really want to, with exercise, be during the neurogenesis portion of stuff, from all the different movement patterns. The other benefits from movement, the angiogenesis, we're getting more blood flow, we're getting more oxygen to the brain. That's something, just by getting people moving, if you don't even think about brain health, just by getting people moving, we're getting some improved brain health, right? Because we're getting more oxygenation to the brain, more blood flow to the brain. Of course, that's a great thing as well. So we certainly want to be increasing the capillary density and all the cardiovascular structures going to the brain. And if we don't ever move, those things continue to decrease as well too, right? We can't just sit all the time. The brain's ability to change in response to experiences, this changes with age, right? When we're young, oh my goodness, can the brain really change in responses to experiences, right? I mean, we're learning very quickly. The amount of effort such change requires, of course, changes with age as well, right? So as we get older, the amount of effort, it takes more and more. When we're 2, 3, 4 years old, doesn't take much effort. We just pick these things up, right? You teach me how to hop and skip and, how to feed myself, right? It's amazing. Like when a 2-year-old figures out how to feed themselves, they don't want anybody to help them feed themselves, right? I know, I got it, right? And of course, that gets wild and messy, right? But it's interesting to see how our brains adapt and learn so quickly when we're little, right? And it takes more effort as we get older, but we still, of course, can be doing this. All right. Okay, questions at all? I got a few more slides I want to cover here. I know we are just about out of time, but if you guys have questions, start typing those in. So The other thing to keep in mind on the physiology of aging is there's going to be such a huge variability. And the point I like to make here is the fourth point. The sooner individuals start training to build their physiologic reserve, the better. And so if you think about investing in your wealth long term, right? The sooner you start, like an 18-year-old has a huge advantage over a 48-year-old. Right. If a 48-year-old starts saving for retirement, by the time they get to 60, they're going, oh man, I should have started sooner. Right. 18-year-old starts investing, putting it away in the bank. They've got a lot more reserve when they get to their 60s. The same is true with all of this physiology of aging. If I am investing in my muscle mass and my power and my speed and my agility and my cognitive function, all these things in my 30s, 40s, 50s, 60s, by the time I get to 70, and begin to see this physiology of aging kick in and these declines happen, I have a much greater reserve to draw from, right? So Howard, who was 94, is the strongest 94-year-old I've ever seen. I've never seen anybody close to him yet. He had a physiologic reserve off the charts. Now, Howard didn't think he was strong. He's like, I'm not strong. I quit golfing when I was 88. 88 is when I quit golfing because I couldn't beat the young guys anymore. Well, he still golfed till he was 88. Like, that's pretty incredible. He had huge physiologic reserve because Howard had done so much activity when he was younger. In fact, when he was in his teens and 20s, he used to toss over his shoulder 100-pound sacks of potatoes, 100-pound sacks of potatoes, tossing those over his shoulder. He grew up on a farm. Continued to do that in his 20s, played all sorts of sports, you name it, he played it, basketball, I think he played football, golf, all kinds of things. Built a huge physiologic reserve. Individuals with a low physiologic reserve, right? People who specialize in sitting on the couch or the rocking chair, eating too much ice cream, spending too much time inactive, they're going to be at high risk of spiraling down into death or disability, right? It's not, oh, I'm 75, so now I can't do it. It's, no, you spent the last 45 years training to not be physically able at 75, right? And so we make that mistake. Sometimes we're like, well, grandma was 78. What do we expect? Like, well, we expected 78 that she'd still be out playing softball or kickball or running around the neighborhood with her grandkids. Why would we not expect that for a 78-year-old, right? I went and played softball recently with my dad, who's 72, and there were guys out there playing softball from 60 to 87, I believe, right? I mean, well, you have to have some level of physiologic reserve to continue to play softball in your 80s, right? It's probably not individuals that are using a cane. I haven't seen too many people play softball well with a cane, right? You got to be able to swing a bat and stand at the, I mean, you have to have a level of physiologic reserve. So let's see here. A lot of this other stuff is getting into geriatrics. But if we think about some of these images aren't coming through. I'm sorry. Let's see if I can get them to work. For some reason, it does not want. See if I can get that to work while you guys are typing in questions. For some reason, it does not want to share my full presentation today. All right, any questions at all?
So Dan, when you were talking about hearing impairment and eye dysfunction and so on, so I would say a fair number of the people that I work with will often complain of dizziness. And I'm just wondering whether it's, I mean, eyes is obvious because if they wear glasses, they can see better, but with ears, they often don't get diagnosed with the issue. I remember one lady I worked with had so much wax in her ears, she just couldn't hear. And so then they start to get dizzy, and then the dizziness leads to imbalance, and then the balance increases their fear of falling. And then they don't want to get off the chair. So is it more associated with ears or eyes, or maybe you can't even answer?
Well, yeah, I can't fully answer to that, but I do always remind people that vestibular function are the little ear tube canals in our inner ear, right? And that's a function of sensing motion and momentum and movement. It's a completely different sense and system from the auditory, how we process sound. And so I can have perfectly normal hearing and vestibular dysfunction. I can have vestibular be completely healthy, right? And I mean, deaf people, for example, often have perfectly normal vestibular function. They're not the same sense. And so now there can be times where we can have both disrupted, right? I mean, we can get fluid on our ear, and we can get a inner ear infection that winds up inflaming both mechanisms, where, we've got ear pain of an ear infection. Typically that's outer ear, when we have an ear infection, which mostly affects kids, but adults can get them too. But we could have an infection that winds up disturbing both, but typically they're not the same mechanism. And so if someone has hearing loss, for example, or they've got, too much wax in their ears or whatever it is, right? Sinus pressure, those are not related to vestibular dysfunction. They're two different mechanisms. Now, they can be perceived similarly, right? So if I'm not hearing well, that loss of that sense could impact my movement quality, could impact my function, but it doesn't impact my vestibular function, my sense of, oh, I'm falling down, or I'm moving too fast, or the room's spinning. Dizziness is typically very common or associated with either a condition as severe as vertigo or some level of vestibular input that isn't quite correct, right? So it might not be full vestibular dysfunction, but if your vestibular system is not giving you good inputs, you will get dizzy because it's telling you the room is spinning or moving, right? If I'm sitting here and my vestibular function is telling me that I'm moving, well, guess what? My eyes are telling me I'm not moving. So now I have a battle going on in my brain, right? My eyes are telling me I'm still, the room's not spinning, but my inner ears are telling me that I'm moving around and around. And so that's going to make me have then the sense of dizziness. And I could even get nauseous, and people will even throw up, right? Because they have a sensory input that's telling them they're swinging on a swing or that they're spinning on a merry-go-round, but they're not, right? My eyes are telling me I'm not. And so that's something you need to see in most cases, a neuro-ophthalmologist or a neurologist, someone that specializes in vestibular function, because if you don't get that fixed, man, it's really hard to function. Even walking across a room is tough. If your inner ear is telling you your room is spinning, it can be a really, really powerful sense. The last thing we want to do is try to walk across a room with our inner ear telling us we're riding on a roller coaster, right? I mean, it's like, that's, if you've never ridden on a roller coaster before, an amusement park ride, the last thing you want to do is try to stand up and walk across a room while, like the reason they buckle you into those rides, right? So that's something you want to see a specialist for in almost all cases, Sally. So that's a pretty significant. So the hearing loss is, unfortunately, from my perspective, and I don't know if this is totally true, but from my perspective, men tend to be even more difficult with it than women. They just don't want to get their hearing checked. They refuse to do it. It's a nuisance. I don't want to wear a hearing aid. I can hear just fine. And so all of a sudden that can actually slip into cognitive decline issues because people aren't hearing everything they need to hear. They're missing out on conversations. They're not as, stimulated or engaged socially as they should be because they can't hear everything, right? Even watching a television show, they're missing stuff. So So we really need to encourage people to get their hearing checked. I mean, I remember my grandmother, it got so bad, she refused to wear hearing aids. It got so bad that when my aunt or my mom would take her out to dinner, people thought she had Alzheimer's because she couldn't hear at all, right? She couldn't respond to the waiter correctly. She couldn't, order at the right time. The waiter would come and ask for somebody's order and she'd be talking over my mom or, and so, I mean, I remember going to the bank with her one time and she couldn't hear at all and refused to wear a hearing aid. And so you almost felt like you were helping someone that was mentally unable to do a simple bank transaction because she couldn't communicate because she couldn't hear, and so then people perceive her, they make this ageist assumption, oh, well, your grandmother's 85, so she must have Alzheimer's, that's why you're here helping her. It's like, no, actually she doesn't. She's sharp as a tack. She's just too obstinate to get a hearing aid, so which was sad for me because my kids, her great grandchildren, never got to have a relationship with her because they'd walk in and talk to her, but she never heard any of it, right? And then, of course, she would think that my kids weren't friendly, even though they'd been friendly to her, right? Greeted her and said hello to her and asked her something. She didn't hear any of it, so it's sort of unfortunate. Any other questions before we go? See here what we've got on the upcoming calendar. I can't remember if this is our last session together. Might be, or we might have a Q&A session on the exam, but I think this was our last session. So since it's our last session together, if you ever have questions or you're having trouble getting through the online course or courses, email us, contact@functionalaginginstitute.com. Me or Celia or Amanda will get back to you pretty quickly. We don't want you out there struggling or getting stuck or feeling like I can't find something. Just email us. We're available if you need something. So yeah, but looking at the calendar, this is our last session, I do believe. So I'm not sure if you have more with Andrea coming or not. I think she's got one next week. I know about that. So any other questions at all? If not, I hope you all have a great Thanksgiving, whatever it looks like this year. Mine's getting more interesting by the day. So it's very, very interesting times. I just found out during this session that my kids are out of school next week. Our school's been put on quarantine. And my college son, his college roommate, tested positive for COVID. So I'm not even sure if he gets to come home. So I'm like, oh my goodness. So, well, it's been fun doing this with all of you. The last thing I will say before we get off is it's really, really helpful, and you can turn your mic on if you want. It's really, really helpful for you to complete the course and get certified and then fill out the MAP form. Too many people do this. They learn all the material and then they never get certified. They don't fully complete it. And if you don't become a functional aging specialist, you can't get on the MAP. We can't refer clients to you. When somebody reaches out and says, hey, I'm looking for a functional aging specialist in Columbus, Ohio, we can't find you, Ann, technically, and we can't refer to you because you haven't finished the test. So I always tell people, finish it. Don't just learn it all, but take the test, get the certification, fill out the MAP form so we can find you, because we have people every week requesting trainers and other trainers are requesting you. That's the other thing. You're going to always be looking for a functional aging specialist because your aunt lives in Georgia or Arizona, or your client moves to Florida and you want to be able to recommend an FAI trainer to them. So, Ann, did you have a question?
Yeah, I haven't started any of the modules yet because I'm still in school.
Sure.
And I'm studying fitness and wellness in the aging population.
Okay.
And it's correlated perfectly with everything you've done, but I haven't even cracked the book for this yet.
Okay.
Is that going to be a problem when I go back? I mean, is it?
No, it's not. I mean, we give you a 6-month deadline, and typically when people do the combo with Andrea's stuff, we always say you can have extra time if you need it. But usually what I tell people is everything that we've done live together, we've gone through almost half the course. And so when you hop in there, it's going to be pretty quick for you to go through physiology of aging and functional fitness assessments and the exercise movements. But if you wait till January or February, unless your brain is not like mine, like all this stuff we just went through is going to not be there anymore, right? You're going to be like starting over from scratch. So I usually tell people, get in there, log in, take quiz 1, because we covered all that material here the last 2 weeks. So you should probably, you might even be able to pass quiz 1 with hardly even looking at the online material, because we covered most of it, you know. So you can start, you know, taking advantage of all the time you've put in. So I usually tell people, log in, spend a couple hours, take quiz 1, see if you can get through quiz 2. If you wait 4 or 5 months from now, if you're like students we've had in the past who do the live workshop, right? People come to conferences, they're like, oh yeah, I'll log in. 2 months go by, 3 months go by, they log in and they're like, oh, I don't remember anything I learned at the workshop. It's like starting over. So I would say get cranking on it as you can.
Can I just say something to Anne?
Yeah.
As a fellow student, I'm busy. I've got a child at home and I've got clients all the time. And I too thought, well, I hope I can fit this in. But I did the first section of Dan's work, the 4 modules and the quiz. I literally did it in just like 2 hours one afternoon. It's not onerous.
Right.
Okay.
Okay.
Right.
And then you take the quiz, and whatever you get wrong, don't worry, because it shows you the right answers.
Yep.
You read it over and you take the quiz again and you get the answers right.
Yep.
Oh,
Yep,
okay.
yep,
So
yep.
you have multiple. I also have test anxiety.
Yeah. Don't have text anxiety, because you get 3 tries on the test. So
Okay.
and I always tell people, and guess what? All you got to do is email Celia and she'll give you a 4th try, because we want you to pass it and get certified and get your CEUs, you know. So don't have test anxiety. Don't do this approach though. People make this mistake. They're like, well, I'll go take the test and I'll write everything down. The second test will be slightly different. You know, we order the questions differently. We might give you a couple different questions. So it's not exactly the same test, but it's designed for you to pass it. We've already covered the material of the first 4 modules fairly well. I mean, not all of it. Like, I didn't read the Physiology of Aging manual to you. You probably should go skim through that, but we covered the highlights, you know. So functional fitness assessments, we covered all of that. I mean, you know, so yeah, don't get overly concerned about how hard the test is or anything like that. So just start doing it, plugging your way through. Sally, do you have another question?
Well, yeah. So I had told you I'm computer illiterate and I don't know how to get at the modules. So what Andrea did was she set up the links for me. So all I have to do, I don't know if you can do that. So if I press on it, then I can get it.
We can totally do that. Yeah.
Oh.
So Sally, the best thing to do is email us and tell Celia exactly what you need, you know. So if you're like, hey, I need someone to keep it simple for me, and she can send you, and if she needs to even hop on Zoom with you, she can, but she can send you the link where you go to log into the course. She'll send you, and we have what we call a snappy login link, Sally. So it's really easy. I use it all the time because I can't remember my login and my password or any of that stuff. So you just type your email in, click the button, and you're logged into the course. And Celia can send you that and help you with that.
Well, unlike Anne, I have this anxiety around, like I just blank and do just awful, and I'm just terrified to do this because I know that I know, but when it comes to it's a language barrier that I have. I think maybe I'm overdoing it here, but I just find multiple choice questions are really hard for me. So I'm hoping that I can see it or do it or whatever.
Okay, yeah, just email us. Celia can help you with that. It's not that difficult. Once you have the website link, it's really not. It's fairly straightforward.
Do you know how to quilt them?
Do I know how to quilt?
Yes.
Absolutely not. That's way too difficult for me.
So let me tell you that It's really easy. All you have to do is buy the material, cut it up, cut it back up, sew it together, cut it back up. It's really easy. That's what it sounds like when you tell me, just go to the website. It's really easy.
Well, what's easy or should be easy, Sally, is to email Celia so she can help you.
Okay.
Because I don't even know how to help you because I don't know your login. I don't know the links you need, but Celia has all that. And she has helped people in their 70s and 80s. I think 86 is the oldest we've had take it. So, and it's not an age thing because I've had people in their 20s that can't figure out how to log in. So
How to log in, yeah.
we've seen it all. So, I mean, people show up to the live workshop when we're at a conference and they're like, there's an online portion I have to log in and there's a test I have to take, and they all of a sudden freak out. They're like, wait a minute. And I'm like, it's not that scary. It's not that scary. You can do it. They're like, oh, I hate online learning. That's why I came to the live workshop. I'm like, okay. So.
Okay, well, I just keep plugging along.
They're always sitting next to the student that has the whole manual printed out in a binder, right? And they look over, they're like, were we supposed to get a manual? I'm like, you got the manual, it's online. We're trying not to cut every tree down by printing a 200-page manual, right? And of course, that student's like, I already passed all the tests, I'm certified, right? And the person sitting next to him is like, Anne, like, what? There's a test? I didn't know there was a test. So it's funny. Live workshops, we always have both ends of the spectrum. So you can do it though, Sally. I know you can. So, but don't hesitate to reach out and ask for help. Email us, contact at Functional Aging Institute. We're here to help you however we need. So, I mean, even if it gets to the point, Sally, where you just need Celia to send you the manual, she can just send you the PDF of the manual. If you're like, I don't want to log in and go manual 1 by 2, she can send you the PDF of the whole manual, and she can send you links to the videos and stuff like that. So
Okay, good.
We can simplify it if we need to. So.
Okay, I appreciate that. Thank you.
Yeah, absolutely. All right, it's been fun being with all of you.
Great. You're a good teacher. Thank you.
I guess it's been 3 weeks now. It's been fun being with all of you. I hope you all have a great Thanksgiving and get certified quickly. So thanks, everyone.
Thanks.
Bye.